HIV/AIDS today, and we are talking about how we are saying that this is one of the key contributing factors of malnutrition. We could call it a condition, or we could call it a group of diseases, or we could call it an illness, really, that will affect us as individuals or as humans. And at the end of the day, if something leads to sickness, or if something leads to a weakness in our bodies, and it leads to wasting, it leads to a damaging of our internal systems, then really we need to take key caution on it. And we are saying HIV/AIDS poses a significant challenge to the nutritional status due to its association with wasting and malnutrition. Like I said, when we are talking of this wasting and malnutrition, we are looking at underweight as a form of malnutrition. Yeah, we are not looking at overweight. However, we are saying challenges arise from the diseases themselves or as secondary effects of the treatment. As we will see, there are some challenges that the individuals will get when they are receiving this antiretroviral therapy, or what we call the ART. And we are saying understanding these challenges is really crucial and key for the effective management and prevention of the progressing of this disease. Looking at its epidemiology, really, we are looking at things to do with a bit of the etiology and the people who are really at risk of this, how it is being distributed here and there. And we are looking at HIV cases being linked to factors like sexual activity, unprotected sex. Then we are looking at homosexual activity. Then we are looking at drug use and sex workers. Really, with a global agenda that is really pushing for this. What do they call it? The LGBTQ something something. They do not want to be told that there are challenges to do with this homosexual activity causing HIV. They will really try as much as possible to say that still there are other factors that will contribute to HIV, so do not link it to only us. It is multifaceted. But really there is a lot of ongoing discussions about that, and these people have a lot of money. No one knows where they get it from, but they do. And we are saying global prevalence of HIV/AIDS exceeds 50 million, primarily in developing countries. When we look at a country like South Sudan, really a country like South Sudan, the last time I checked, I think that was 2021. You people had a population of about 11 million. 11 point something million in 2021. So as of now, okay, adjusting for a few things here and there, the displacement of people, we are looking at roughly around 12 to 13 million as a population in South Sudan. But we are looking at the worldwide numbers of people suffering with HIV being 50 million. Now that means that number of people suffering with HIV are more than the number of people you have in South Sudan. So you can picture that and understand that this is a real disease or an endemic that we really need to be looking at. So globally, we are saying most of these cases are in the LMICs due to limited resources, the infectious diseases, the food insecurity, and the social and political issues. We realize all these are key contributing factors. With the limited resources, you understand that if people do not have the resources, if people do not have money to look for food, if they do not have opportunities, they will do as much as possible. Some people will engage in selling their bodies, and also some people will due to these social and political issues. For example, wars. I don't have to explain this to you, but you understand where there is insecurity, the crime rates are high. Then we will start suspecting of rape, and then the transmission of HIV will be rampant. So transmission and prevention of HIV, we are saying modes of transmission include blood-borne contact, okay, direct contact with the infected fluids, and unprotected sex, the needle sharing, and also mother-to-child transmission. And this mother-to-child transmission really has reduced, because even in our LMICs, all the low and middle-income countries, we understand that there are all avenues, there are steps that are being taken to eradicate this mother-to-child transmission. The PMTCT, if you're working in health centers, you really know that the efforts are really ongoing. And also we are saying prevention efforts through education, safe sex practices, and then the needle exchange program. When we talk of the needle exchange program, really for those developing countries, however, if there are 95%, then up to 95% sure that the results of this study are correct. I can say that if I have an sorry about that. When we are talking about these needle exchange programs, we are looking at those developed countries that have a lot of high rates of drug abuse, okay, and drug use. These needle exchange programs come into play for places like there is that famous place, I think it's called Philadelphia. In they are using all the types of drugs. They are using this drug that makes people zombie like from horse vaccine. I'm forgetting its name. It's called fentanyl. Okay, they are using fentanyl, and there is a lot of fentanyl drug use that side. And this is a drug that someone needs to inject themselves. However much these people are addicted to drugs, we do not want to exacerbate this, so that the person is addicted to the drugs and they are getting effects from those drugs, but also they are getting challenges to do with HIV. So that's where these needle exchange programs come into play, where they are distributing these needles, they are distributing sterile needles, they are distributing these places where those containers for the disposal of those needles after use, so that other people cannot reuse them. But really, it looks like a contributing factor to drug abuse. Okay, where if people are being provided with needles to go on injecting themselves, I think it looks more like drug abuse. So they've said, okay, drug abuse is fine, but then HIV is not fine. I'm not so sure of how this discussion can go on, but I believe you people can also have some inputs to put therein, if that is a discussion for another day. We are looking at education. Looking at education, there has been a very a real struggle between the parents and the school governing bodies about this sex education. Okay, they are introducing sex education to schools, looking at the ages of children who are going to be taught these acts and etc. So a lot of information is there, and a lot of discussions are still ongoing. But these are efforts really that are in pipeline to help and prevent the transmission and distribution of HIV. So when we talk of the clinical stages of HIV, we are looking at HIV/AIDS is classified in 4 or 3 clinical stages by the CDC Center for Disease Control, and the WHO, World Health Organization, where we are looking at one being the acute infection, then the symptomatic latency or the chronic HIV infection. Really, some people have been found to divide these, but really they are more of the same. Then the final stage and the last stage is the AIDS, and we'll see what all these stages mean as we go further in our engagements. Beginning with the acute HIV infection, we are looking at the first stage of infection, which occurs in 2 to 4 weeks after exposure to the virus. After you've slept with after you've had unprotected sex with a person with a high viral load, this is what happens. Symptoms including fever, the rash, the headache, and the swollen lymph nodes. You know, those lymph nodes help us detect the different antibody, the different the different viruses or the inflammation activity that is going on. And also, these help us trap some bacteria and viruses, I should say. And we're saying that here, this is the problem that we used to face here in Uganda. In Uganda, we have a village that is called Masaka. Actually, it is a district now. Masaka had a challenge. Whenever they would get this fever, a person gets the rash, they get the headache, they get the swollen lymph nodes. In the 80s, people would say that this is witchcraft. Okay, so our understanding of HIV was really limited and based only on tradition. Okay, yeah. So people would think that this is witchcraft, and really it claimed a lot of lives. of people. However, we are saying treatment can help reduce the viral load and prevent further damage to the immune system, as we will see. And for the chronic HIV infection, we are looking at this as the second stage of the infection, which we could call also as the asymptomatic HIV infection or clinical latency. When we talk of a latent period, in whatever way, wherever you will find it, latent means dormant, okay? And something being dormant, that doesn't mean that it doesn't exist. It is there, but then its effects are not being felt as they would be felt in other phases or other stages of development. Oh, okay, we are saying that during this stage, the virus continues to multiply in body, but very in the body, but at very low levels. And we are saying symptoms may be absent or mild. Okay, yeah, and the risk of transmission is really reduced, but it is still possible. Okay, yeah, but it can be seen really. It can be seen after using those strips to test it. It can be seen, and treatment can help maintain an undetectable viral load and prevent progression to AIDS. Okay, yeah. For the AIDS or the acquired immune deficiency syndrome, we are looking at this being the final and the most severe stage of HIV infection, which occurs where the virus severely damages the immune system of an individual. Okay, and we are saying that the CD4 cell count drops to below 200 cells per cubic millimeters of blood. And here are the symptoms, which will include the chronic weight loss, the chronic diarrhea, the night sweats, the fever, the cough, and also those other opportunistic infections. This is the period where we will see TB also starting to manifest, and we are saying the risk of transmission in this is very high. So here treatment can help control the virus and also improve on the quality of life. However, we can also realize that at this stage there is not a lot of transmission taking place really, because a sick person can now be seen. Okay, there is evidence of these clinical signs and etc. And when we talk of the pathophysiology and diagnosis, we are saying that the HIV infection causes the immune deficiency and also leading to vulnerability due to those opportunistic infections, I should say. And we are also saying that the virus converts the ribonucleic acid into a DNA using reverse transcriptase integrating into the host in the integrating into the host DNA. Okay, yeah, and we are saying that when we talk of this nucleoside reverse transcriptase, really now that the virus is as if trying to take over. Okay, the virus is trying to take over from you, the individual. So the virus, when we are talking of that diagnosis, really we are diagnosing this through ELISA screening, Western blot testing, and then the RNA viral assays for early detection of this particular challenge. And when we talk of the ELISA technique, here we are looking at this relies on that technology of the binding affinity between that antigen and then the corresponding antibody. So it will really help us in the diagnosis of this. A lot of things can be talked about that, the coating, the blocking, the sample incubation, etc. But really, that is a small brief of what we can talk about that. Okay, continuing, we are looking at the impact of this HIV on the nutritional status of an individual. When we look at the malnutrition, malnutrition documented, malnutrition is actually documented in all HIV/AIDS stages, from the acute to the latent and also to the AIDS stage itself. And we are saying this is affecting the treatment outcomes, however much a person is being treated. But then there is malnutrition paired with immunosuppression, paired with uh, low, paired with wasting DTC, still will be opening up space for more opportunistic infection. And we are saying it is important for early detection and also intervention in managing this HIV/AIDS effectively. Also collaborating with those healthcare systems, the community, and also different policymakers to come on board to address this impact globally. Okay, yeah, we realize that a few organizations are out there here in Uganda. I don't know whether it's everywhere. We have TASO, the AIDS support organization here. Then we have also Uganda Cares, but really we have CDC at the forefront of this, and then USAID is also doing something. When we talk of counseling, really we are looking at counseling of those individuals that we have found to have this HIV being crucial, okay, to support and also give to the information to navigate the complexities of this condition. Things to do with the drug use, okay. People have reported having illusions whenever they are using these anti-treatments or these antiretroviral therapy drugs. Okay, yeah. So we need to explain well to the people that you can start so that you can be able to prolong your life. However, we have a little of these side effects, but it is a price to pay for you to achieve a little better well-being. All right. Medical significance and limitations of testing. We are saying while a positive result indicates presence of a virus, a negative result may not necessarily rule out infection due to that window period and also possibility of the false negatives. For people who have done a little bit about immunology or about epidemiology, you know that 2 by 2 table where we have the true positives, the false positives, the true negatives, the false negatives, and the true negatives, etc. And only maybe a brief when we talk of a false negative, that is one who is tested negative, but in actual sense they are a true positive. You will see that when you look at epidemiology later on, maybe in this module, maybe in a different module or at a different stage if you're going to proceed and do a master's in public health or a master's in whatever health, really epidemiology is key. We are also saying it is essential to discuss the limitations of testing to ensure patients have realistic expectations. Okay, yeah, and also we are saying whenever you test, at least do a confirmatory. Don't test once and go and celebrate after you being careless with your life a little bit. Go on and do another testing so that you can understand how you have, whether you have this virus or not. However, some people are saying if you keep on testing, whatever you're searching for, you will find it. But really, testing is key for early identification and easing in management. When we talk of these newly diagnosed patients, they need comprehensive information about HIV and AIDS, including how the virus is transmitted and the methods of prevention, so that they can be the people out there, they can help us and also educate people. And others have even become ambassadors of HIV. Okay, taking HIV to schools. This is not something that we should hide from children because once you get it, there has not yet been a cure for it. There are just injections that are being discovered right now. There is that injection of 3 months, I think. So we are seeing there is that injection of I think 3 months, rather than the daily tablets. Someone can take this injection of 3 months, and they can be okay. Now there is PEP, the post-exposure prophylaxis, then the PrEP, the pre-exposure prophylaxis. These are things we need to talk about. If a person has HIV and then the partner does not have, still this doesn't call for divorce or separating. but really there are key ways in which these people can live in harmony. And also availability of medical and nutrition, social care. We are looking at access to medical, nutritional, and this care being essential in management of those people with HIV. Okay, so for these newly diagnosed patients, they should be informed about the availability of healthcare services. Actually, when I was interning with the AIDS support organization in Masaka, we used to take these drugs to people. We used to take for them their refills. We used to do defaulter track for whoever has not yet come for refill. We go to each and every place in the village wherever they are. But due to some funding constraints, really these things are a little bit challenging. We used to also provide good avenues for where these people will pick their drugs from. Okay, because we wanted to remove or to avoid that stigma of people seeing you, or even our cars. Whenever we would move with that Land Cruiser to go and deliver those drugs. Yeah, sorry, I was saying that whenever we would move with that Land Cruiser to go and deliver those drugs, we would park at a distance. Okay, then we would move on foot to go to those homes with different clients or different patients, so that people cannot get to know, so that they do not stigmatize that individual. And also the other thing that we would do is try as much as possible to shorten on the distance where these people are supposed to pick those drugs from. So we would be distributing drugs daily. Also, confidentiality and social or legal implications. This we've seen. And we are saying it is paramount to care and protect for the patient's privacy and prevent discrimination. You know, when you enter the health field or the health sector, and you should be a little bit tight-lipped. And when I talk of tight-lipped, what do I mean? You should not be discussing everything that you've had on a client. Okay, you should have that integrity within you. The only time we discuss a client is actually we are not even discussing a client. We are discussing a case. Okay, even when you're seated with your fellow doctors, all you can say is, we have a client who is suffering from hypertension, who is undergoing domestic gender-based violence or whatever, who is undergoing this and everything. You understand? We even do not mention the patient's names. Or the only thing you can do is mention the patient's bed if they are admitted, or given these numbers, those numbers that we write on the books. I'm forgetting what the numbers are, but in the integrated nutrition registers, we call them NRA number. Okay, so for the patients, patients should be educated about confidentiality laws and potential social and legal consequences of HIV testing, including the stigma, the discrimination, the disclosure issues, and also establishing those support systems, and also accessing legal assistance may be necessary for addressing these concerns. If a person feels very stigmatized, there should be leeway for this person to report whoever is mistreating them to the local authorities. This will help other people be able to declare that they have HIV, because they know there won't be an impending threat on their life. Okay, and really, when we address these concerns, we will see a lot of people coming out to disclose, and we'll be able to treat them, and also we'll be able to broadcast this message of prevention as much as possible. When we talk of the medical management of HIV, here we are saying while HIV elimination is not yet possible, like I said, there is not yet a cure for HIV. Maybe the different people who are on this engagement, that side, really who are attending this class, maybe one of you might get a Nobel Peace Prize of understanding or of getting this cure for HIV. However, as of now, 2024, as I speak, there has not been a cure. But there are different efforts that are ongoing for people to get at least a little bit of these antiretroviral treatments. The combination antiretroviral therapy is the cornerstone of HIV treatment, suppressing the replication, and also trying as much as possible to restore the immunity of an individual. Then when we talk of the antiretroviral therapies, we are looking at those different medical cases, okay? Yeah. And we are looking at those nucleoside reverse tri, tri, nucleo, nucleoside reverse transcriptase inhibitors and those non-nucleoside reverse transcriptase inhibitors as the different classes of this antiviral therapy, where we are looking at these NRTIs, which interfere with the activity of an enzyme called the reverse transcriptase, which is essential for the HIV replication, and also others could help in binding to that enzyme. Okay, yeah. For example, the non-nucleoside reverse transcriptase inhibitors, these reverse the transcriptase inhibitors, but work by binding on the different side of the enzymes compared to the NRTIs. Also, those protease inhibitors, these ones also target another key enzyme for HIV replication, which is called the protease enzyme. Okay. Uh, so for the importance of adherence to the treatment, really here adherence to this antiretroviral therapy is critical for achieving a viral suppression, okay? Reducing the amount of virus or in blood in a layman's language, and also preventing drug resistance, because there is the first line, the second line, and the third line for people with a medical background. These things, and we are saying and we are saying patients must understand the importance of strict adherence to the medical regimen, and also are supported in overcoming those barriers to adherence, such as the side effects and also the complex dosing schedules. So, friends, when we talk of the goals of the treatment, we are saying the primary goal for this treatment is really to delay a disease progression and also prevent those other opportunistic infections, okay? And early detection, initiation of treatment, and comprehensive care are essential for achieving these goals at the end of the day. And we are saying, in addition to the conventional medical treatment, patients may explore those alternative therapies such as the herbal remedies, the acupuncture, the massage therapy to complement the HIV management, to alleviate stress, okay? When we talk of acupuncture, this one is a traditional Chinese medicine stimulate energy flow throughout the body. It is a very interesting topic, and as other people have talked about it, helping in lifestyle changes you might get interested. Please go and read about. Right. So, for the nutrition status during HIV infection, we are looking at HIV infection can lead to malnutrition due to those metabolic changes, the decreased nutrient intake, the gastrointestinal issues. Assessing and addressing these nutritional needs is really key for optimizing the treatment outcomes. However much you're putting someone on these antiretroviral therapy drugs, there are some challenges. For example, people who are taking what is that drug called? Is it DTG? I think it is DTG. Some people have reported that loss of taste buds, okay? Loss of taste buds on the tongue. They are no longer able to feel any sweetness. They are reporting of tongue numbness. So, you as a nutritionist, you need to know that there is decreased intake. But how can you stimulate eating after? People have come up with some remedies. One of the things I've seen someone do or someone advise was for people who lack appetite and their taste buds are having challenges, to be given a lemon to stimulate their sensory activity. And it has been proved to work some in some places. And some places say that after someone has been given a lemon, they will feel hungry and they will want to eat, however, whether they are tasting the food or not. But that is an issue for discussion later on. So, the importance of good nutrition in HIV. We are saying good nutrition is essential for supporting the immune function, managing those symptoms, and also improving the medical efficacy of these people living with HIV. Okay, yeah, a balanced diet. You know what we talk of. We are talking of that meal or that those groups of meals that are containing the different food groups from the different food groups, the proteins, the carbohydrates, the fruits, and the vitamins and etc, and also make this information understandable. Don't go telling people about the different minerals and what they do, the different vitamins and what they do. Talk about a particular food. When you talk of vitamin C, don't talk of vitamins. Talk about a fruit. Okay. When you don't talk of a protein, talk about that nutrient that you get from meat, from fish, from eggs, from milk. That's what our lay people understand whenever you go to sensitize the communities out there. And also, we need to, as much as possible, encourage these people to seek support, to seek help, so that they live a better life. And we are also saying nutrition assessment is key, is a critical component of the nutrition care process. This we saw used by those dietitians. In the nutrition care process, we looked at the nutrition assessment, the nutrition diagnosis, the nutrition intervention, and the nutrition evaluation and monitoring. I hope you remember. Saying this involves a systematic approach in gathering and analyzing the information about a patient's nutritional status, the needs, other goals. You will see that a different, when we are making a nutrition diagnosis, a cause of the malnutrition or a cause of the challenge is really key. And we are going to be looking at it in detail at some point. Okay, so for the components of the nutrition assessment, we are looking at dietary intake, this we saw, where we are evaluating the person's dietary habits, including what foods do they like, how do they eat, when do they eat, what do they eat, and also how are those foods prepared. It's key that people really forget that preparation is also part of dietary assessment. Psychosocial issues such as comorbidities, here we are examining the psychological and social factors that may impact the person's nutritional status, the mental health conditions, the socioeconomic status, and social support. There was some information that we got that at advanced stages of HIV, people tend to get psychosis. Okay, yeah, triggered what we call it is okay. People link it to mental illness, but yeah, really we need to assess for all this. And for the food insecurities, we are looking at insecurity maybe due to access, maybe due to availability. Why is the food not enough? How is the nutritious food supply chain? Also including all those barriers to obtaining food. Is the food not there in the market? Even if you prescribe, even if you write a good diet plan, even if you tell people of the dietary intake and the food is not available, they won't take the food that you're prescribing. Medications, here we are looking at review the medications prescribed for the management of HIV and any potential interactions and side effects are related to nutrition. You know, the drug nutrient interactions. Hopefully, we will cover something there at an advanced stage in this course that you're doing, or you covered it somewhere. So, the ABCDs of nutrition assessment, we are looking at environmental behavior and psychological assessment, the living situations. But the ABCDs of nutrition assessment are anthropometry, biochemical assessment, clinical assessment, and then dietary assessment. But really, we are looking at this yeah, in more tune with the HIV or with the AIDS. We are looking at the environmental behavior and psychological assessment, the living situation, understanding how this patient is living and how they are able to access. Do they have the preparation facilities at home? Do they have that charcoal to cook the food, or the gas, or the electricity, etc. Personal support, here we are being able to, it is key to identify sources of support, including do you have any families or the relatives? Do you have those community support groups where people with HIV meet? That's why we even have a World HIV Day, something like that, where we need to understand or celebrate the lives of these people because they are battling HIV on our behalf, because as a human race we are all one. For the food environment, we are looking at evaluating the availability and affordability of those nutritious foods and options in the patient's community. And if they can't afford this, that is when it comes to the nutrition supplementation, where people are given the root of, I think they used to be given root of, I'm not so sure about what it is right now, but then they are supported nutritionally with that. Okay. Also, we are looking at really the eating assistance, assessing for the patient's ability to independently obtain and prepare the food, and also need for assistance with eating. So, what are the goals? Really, we are trying as much as possible to enhance and also lengthen the life of an individual. Really, earlier on when HIV had just emerged, people would not spend a year, but people are living with HIV to more than 40 years, more than 50 years, and it is a really a good success in the public health field, reducing morbidity, minimizing the risk of those other nutrition related complications, and improving the management of the comorbidities and also those other conditions. Really, you see that when someone is malnourished, they are going to have these micronutrient deficiencies. And those micronutrient deficiencies, coupled with the immune suppressing effect of HIV, really a person might not really take a lot of time still alive, the person might die. So, in our attempt to minimize these nutrition related complications, we are trying as much as possible to enhance the quality and also lengthen life. Maintaining the nutrition status here, we are looking at preventing malnutrition, preserving the lean body mass, and also support the immune function, and also managing those comorbid conditions that really are addressed. Here, we are looking at addressing those conditions such as the obesity, the diabetes, the hyperlipidemia. Hyperlipidemia is if there are a lot of lipids in blood, the triglycerides and the cholesterol, etc. And then for the nutrient requirements, we are looking at the adequate energy intake, which is essential to prevent weight loss. You know that the body will turn to the proteins at the end of the day. Then the proteins may be needed, may be higher in individuals with HIV due to particularly those with asymptomatic or as experiencing the wasting. And also the fat and micronutrients. We are trying to emphasize the very diet of those essential fats and micronutrients to support overall health. As you will see later on, that different different drugs try to bring about lipidostrophy and hyperlipidemia, where we are seeing a lot of lipids in blood, which could cause thrombosis and all those other things that could bring challenges to an individual. So, assessment of height, weight, and body composition, the MUAC or the mid-upper measurements provide valuable information on the nutritional status of disease progression. If you didn't read anything about anthropometry, please go and read. When we talk of the biochemical indexes or indices, we are looking at the blood tests ranging from the serum proteins, the liver function tests, because it is the liver that is required in filtering those toxins. And for the people with that third, for people taking the third line drugs, really the liver is overwhelmed. Okay, yeah. Sorry. For the clinical observation and diet evaluation, here we're looking at the general signs of malnutrition, the weight loss, the muscle wasting, poor wound healing. All these should be monitored. For dietary evaluation, we are looking at you assessing the intake, including any restrictions or modification related to HIV treatment and management. Like I told you, of those drugs that really discuss here, we are looking at the metabolic and body composition changes due to the antiretroviral therapy, the lipidostrophy, the abnormal fat distribution, and the hyperlipidemia. And these are the side effects that need to be discussed, and these may impact the nutrition status, including insulin resistance. And when we talk of insulin resistance, we start to suspect of diabetes mellitus setting in, leading to hyperglycemia and also other lipid abnormalities. That is why some earlier on we used to see a lot of underweight, but really now there are also overweight cases in HIV. But in our LMICs, really, there are cases, but really they're very few cases. And some people even attribute it to the drugs, and they say, yeah, I'm growing big because of the drugs that I'm being fed. However much other people have also are given. Actually, this is, I think, the reason why people are giving ARVs to pigs, so that these pigs fatten in size. I'm not so sure, but I hope you've heard of the story. So, what are the counseling principles when someone has HIV? We are looking at using motivational interviewing, patient-centered counseling techniques. Try as much as possible to empower these people to make the choices for themselves, not to imposing on an individual. When we talk of education, we are looking at providing that evidence-based nutrition education to improve the understanding of the role of nutrition in managing HIV and also promoting healthy eating habits. Supportive strategies, here we are looking at offering that ongoing support and also encouraging to help these patients overcome barriers to optimal nutrition and also achieve their health goals at the end of the day. Now, Zolang, your hand is up. Oh, I think you just forgot.
Hello.
Yes, hello.
Oh, sorry, I have just realized I was on mute. Which slide did you
All
stop
right.
hearing from me? Was it this?
No, no, not this. This is not the one. Yeah,
The,
yeah, this is the
the
one. Of
three.
course, this is the one.
This
It
is
is the
it,
one.
right?
Nutrition counseling. Yeah.
Oh, sorry about that, my friends. You know, I'm going down with a flu, though it is improving, but then I have to take those breaks. I hope it's okay with you to catch
All
my
right.
breath
There's
at
no
the end.
problem.
Yeah. So for the nutrition counseling, we are looking at using those motivational interviewing. We are talking of the patient-centered approach, where you're not imposing your techniques on an individual, but really you're trying as much as possible to let in the patient or the treatment of how you're going to be managing this condition. Also, for the education, you are looking at you using that evidence-based nutrition education to improve the understanding and the role of this nutrition in managing HIV. You can ably tell them that with impaired nutrition, these are the consequences or the challenges that you will be facing, and this person will take on that particular behavior due to those perceived benefits that you've linked to other perceived threats or whatever the case it is. I think you will interest yourself with the health belief model, the HBM, and you will understand of the triggers to change and all those other things. Supportive strategies, we are looking at offering ongoing support, okay, for these patients to overcome those barriers to achieving a normal nutritional status. For the anorexia, we've talked of the anorexia nervosa, the anorexia bulimia, where we've talked of now the person does not want to take in food because they feel at the end of the day they will be dying. So they are like, okay, now what is the use of food anyway? And when we've also looked at the reduced sensory bit of the tongue, they are taking in the foods, they are getting a metallic taste from the drugs and etc. And we are saying it is critical to begin these interventions early, and also starting to educate people that these things could happen, and also tell them about the role of nutrition in managing this. Wasting syndrome, we are saying, remains very common in people receiving this heart or the highly active antiretroviral therapy. If it is inaccessible or underutilized, this is where the default has come into play. People who are not adhering, they are taking drugs today. Okay, defaulting is when the person is not coming to pick drugs at the health center. But then we also have those at this particular time, but you'll find that this is a person who is ever busy, whoever forgets to take the drugs, and really we will see all that. And for then we are looking at the indicators for malnutrition. We are looking at weight loss of more than 10% in 1 month, coupled with things to do with losses due to diarrhea, weakness, and also fever in the past for over 30 days could be an indicator of malnutrition. And we are saying this is a significant predictor for morbidity of the people living with HIV. So, for the inadequate intake, looking at factors that contribute to wasting, we're looking at inadequate intake, malabsorption of these nutrients due to the food intolerances, the antiretroviral therapy, the gastrointestinal issues. Like we had discussed, how do we manage issues of these gastrointestinal issues coming into play, and low levels of serum albumin and zinc deficiency exacerbate malnutrition. So addressing the underlying causes of malnutrition is crucial, along with fat and lactose restrictions, and using the lactose-free supplements, probiotics and prebiotics, the glutamine, the arginine supplementation. All these can help us in malabsorption. Okay, manage the malabsorption so that now the food that a person is taking in can really be of beneficial use to the body to provide energy and those different other nutrients. Also, attention to energy and protein and fluid adequacy is essential during treatment. Really, counseling is key for when we are managing these people who are living with HIV or the HIV/AIDS clients. So we are saying this is it aims to make minimal lifestyle changes, also promoting optimal nutrition status, and also we prioritize the needs and also provide clear explanation of the benefits, risks, and also fostering sustainability and agreement between you, the patient, or you, the service provider, and that patient. So here it helps us also take those manageable steps in order of complexity to the difficult ones to facilitate the patient's compliance. Okay. So if you're trying to indicate the foods, let's start with those small frequent meals so that we increase on quality. Let's begin with the foods that people want. Let's look for those foods that are available locally, and also those ones that people do not find to have food tables on, and etc. So, what are the special considerations for children with HIV? Those that who got it from their mothers, etc. We are saying growth and development are additional concerns, and in the pediatric HIV cases. Here we are looking at CDC screening, monitoring the evaluation, also treatment, and emphasizing prevention of dehydration, and also dietary adjustments to take into consideration since these are immune compromised cases. When HIV/AIDS is a common problem, and we are looking at the loose watery stools often with increased frequency. Okay, people claim around 7 to 8 daily episodes of diarrhea for these cases. Main causes include infection, increased motility, and also the medication side effects. Really, if someone is diuretic, we know what to indicate and what not to indicate. We know the insoluble fiber, a lot of things here and there. Then the hydration is also crucial for diarrhea relief. and also keeping dietary food diary and identifying those foods that trigger or bring out or exacerbate the diarrheal episodes, and also emphasizing safety and sanitation, because these are also key that will prevent further conditions or the conditions from worsening. Really, at the end, we are just looking at the malnutrition cycle of wasting. Malnutrition exacerbates wasting, creating a vicious cycle that requires integrated interventions. And also, treatment is complex due to other factors that cause malnutrition and wasting. So, friends, today we have been looking at HIV, really looking at the different stages of HIV and the medical management of HIV, looking at the importance of nutrition, looking at counseling as also a key intervention, and also focusing really on the patient-centered approach. So, friends, I aim to stop here for today's engagement. If there is not anything, then I wish you a nice week. Yes, Zola.
Yes, hello, sir.
Yes, please.
Yes, thank you very much for the presentation.
Yes.
Yeah, so mine is just a request. So I'm just requesting